Hi everyone, hopefully you can hear me. We're just going to wait another couple of minutes because some people are joining right now. So we'll just wait a couple of minutes and then we'll get started. So there are some people still joining, but just to be mindful of time, we'll get started. So hopefully everyone can hear me. My name is Nicole Cork. I'm the Association Manager of iHEA's activities. Welcome and thank you for registering for today's Universal Health Coverage panel on COVID-19, which was made possible by a grant provided by the International Development Research Center. Today's webinar is presented by the Financing for Universal Health Coverage Special Interest Group and is being translated live from English to French and vice versa. So if you prefer to listen in another language, we encourage you to adjust your language at the bottom of the screen. You should see a drop down at the bottom that says your language, so you can switch from French to English there. The webinar will run for approximately 60 minutes, and we are recording it, and it will be uploaded on our website afterwards in both languages. Before we begin the webinar, I just wanted to run through a couple of housekeeping items. If you do experience any technical issues during today's webinar, please contact technical support by clicking on the question mark on the bottom left of the screen. Everyone on the line has been muted except for our speakers, so you won't be able to unmute yourself. Please use the chat box for any questions or comments during the webinar, and they will be addressed at the end. Finally, we will also be sending a brief survey out following this webinar, so we do encourage everyone to complete this as it's important in terms of offering future multilingual webinars. I'm now going to pass it over to Virginia Wiseman, who is one of the conveners of our Financing for Universal Health Coverage Special Interest Group.
Hi everybody, it's great to have you all with us today, this evening, this morning, depending on where you are. As Nicole said, my name is Virginia Wiseman. I'm the coordinator of the Special Interest Group for Universal Financing for Universal Healthcare Coverage. I might just quickly mention that if you are interested in taking part and presenting in any webinars for our Special Interest Group, then please do get in touch. We're always looking for presenters. And if you'd also like to perhaps make any suggestions on other activities for the Special Interest Group, then again, do get in touch. We're very open to all suggestions. So tonight we're very fortunate to have not one, not two, but three speakers from WHO Geneva, from Indonesia and the Democratic Republic of Congo. And before you are presented to all the speakers, I'd just like to introduce Karen Greppen, who is Associate Professor at the University of Hong Kong. She's in the Health Economics Policy and Management division there, and she's going to be our facilitator for this session. So thank you, Karen, and thanks to all our speakers. Over to you, Karen.
Thanks, Virginia, and thanks, Nicole, for all the logistics and getting this off the ground. So yes, my name is Karen Greppen. I'm in Hong Kong. Good day, good morning, good afternoon, whatever it is for you. My role tonight is I'm going to be moderating the session and, most importantly, answering your Q&As, moderating the Q&As. So if you have any questions during the sessions, please put them in the channel. I'll be moderating them, and at the end, I'll bring them forward. So tonight we have 3 different speakers. I'm briefly going to introduce all of them up front so that you have a sense of who they are, and then we'll move through them. Each presenter will have approximately 10 minutes to speak, and then we'll hopefully have some time at the end to chat. So clearly COVID has changed a lot of things with how we think about health financing, how we think about health systems, how we think about universal health coverage. And each of the speakers tonight has had some experience either in the current COVID pandemic or in previous outbreaks and dealing with issues related to what many countries are dealing with today. And so we've brought them all together to share some of their experiences with this group tonight. So our first speaker will be Dr. Hasbullah Thabrani, who is the Chief of Party of USAID's health financing activity in Indonesia. He'll be talking to us about reimbursement in the National Health Insurance Scheme. He is a professor and a former dean of the School of Public Health and chairman of the Center of Health Economics and Policy Studies at the Universitas Indonesia, amongst many accolades. He also has a medical degree from the Universitas Indonesia and degrees including a doctorate from the University of California. Next, we'll have Dr. Serge Mayaka, who is from the École de Santé Publique at the University of Kinshasa in the Congo. And he'll be presenting actually some work that he and I have worked on together on free healthcare in the context of the Ebola outbreaks in the DRC. He, as well as a medical doctor, and has some degrees at the School of Public Health at the University of Kinshasa, and a PhD in public health from the Catholic University of Louvain in Belgium. And our final speaker is Dr. Susan Sparks, who is a health economist based at the World Health Organization in Switzerland, and she'll be talking to us about financing common goods for health. She has 15 years of fiscal experience, health financing, health systems research in countries around the world. She has a doctorate in health economics from Harvard and a master's in economics from Tufts University. So with that, I will pass it over to our first speaker, Dr. Hasbullah Thabrani, and to get us started. And again, please.
Thank you, Karen. Thank you, Virginia. I'm Hasbullah Thabrani here in Jakarta. Good morning, good afternoon, evening, wherever you are. Thank you very much for the opportunity to share a little bit about the Indonesian experience during this COVID within the National Health Insurance, or often we call it universal scheme. Can I navigate? Okay, so the health financing before the COVID is divided into 2 different big category in Indonesia. This is the policy first for the public health programs, where the beneficiaries are the community, not individual. It is it is financed by tax that managed by Ministry of Health and regional health offices. While for individual healthcare, personal healthcare, it is financed through National Health Insurance Scheme. We have experience using social health insurance scheme in the last 50 years. So we are expanding this national health insurance based on social health insurance and tax funded. We call it JKN. It is in English, it's National Health Insurance. That's Indonesian word. The JKN is financed from payroll deduction, 5%, and some nominal amount for non-employee. The coverage now 224 million people under the single payer system, or 80% of the population. This is the scheme, the flow, and you can see during the JKN, or for the JKN, we use prospective payment for all benefits, cover comprehensive benefits, capitation for primary care and case mixed group, or a modification of the RG for hospital care, both for inpatient and outpatient. In addition to that, there are some top-up payment for special drugs such as cancer drug that cannot be grouped with because of the outlier if we take it the average. So that's the situation. The claim process for the JKN, certainly for capitation payment, pay in advance, and all transfer electronically to contracted primary healthcare providers. Currently, there are about 23,000 primary healthcare providers, and for hospital, currently there are about 2,600 hospital, public and private, are contracted by the National Health Insurance. Payment to hospital after clean claim submitted is about 15 days. That's the maximum days that the law regulate. So during the COVID situation, the financing is a little bit different because for the COVID, the all patient, whether they are members of JKN or not member, are covered. All people who live in Indonesia, including expatriate foreigners, are covered. So the coverage of the COVID is nationwide. This is the Indonesian map, and this is the map of risk factor. Currently, the government categorize all about 580 districts by green, red, and yellow, depending on the risk status. We are having increasing trend together with India, although the number of cases reported only is about 550 now cases per million population, about 1/4 of the Indian cases and 1/3 of the Pakistani cases. This is the cases for countries with more than 200 million people. But Indonesia and India still in the upward trend. The payment, the coverage for the COVID funded by the national budget cover rapid and PCR tests for the traces people. So not for everybody at this time, for those people who have a history of contacting patient or people who have contact. Personal protection device for outpatient also covered by the national budget. Emergency hospital costs are covered. All hospitals, regardless of contracted in the JKN network or not. All hospital expenses are covered. Dead body bags to be burial, and the government also provides special incentive for health personnel who are working with COVID. This funding is a little bit split. For the testing and treatment, it is decentralized to local government. So local government are authorized to refocusing their budget to focus for the COVID during this pandemic. While for the healthcare, that hospital provide services, it's funded by the national budget, and using the JKN claim processing because that's been established. Although some hospitals who are not contracted, not in the network providing healthcare, but they still have access for that one. For the payment, we use different way. We cannot have the CBG or the RG code at this time because of new cases. Instead, the government, the Ministry of Health, said per diem. It's called per diem or per daily reimbursement. The process through electronic submission. The group divided into two big group, which is with complicated or comorbidity and without complicated and without comorbidity. Within each group, there are six groups that the hospital could claim to the Ministry of Health. For example, here I give you the table in Indonesian rupiah, that's Indonesian currency in million, yeah, because our exchange rate is $1 US dollar is about 14,500 Indonesian rupiah, and in parentheses there are amount of money per day for US dollars equivalent. So we have division on the ICU with ventilator, without ventilator, isolation, with negative pressure plus ventilator, and isolation in the hospital with without negative pressure, isolation with normal pressure, and so on. So that's the division that we categorize for simply simple claim reimbursement. The problem with that is before the COVID, all hospitals have a relatively high occupancy rate, but during the COVID, because people are afraid to go to a hospital, although they are covered under national health insurance, they didn't go, and therefore most hospitals experience dropping in their revenue and their patient between 30 to 60%. Many doctors also stop practicing in a hospital, and therefore many private hospitals suffering from serious financial problem. Even they have to lay off the nurses and employee. So far, by last week, about 83,000 claims already submitted, but payments remain low because of the problem. Some hospitals have not fully submitted the documents needed, and also verification by the JKN or the BPJS in Indonesia remain relatively slow. So we have a problem with this payment because absorption relatively low. There is a rapid policy response for financing. However, the absorption relatively low, even though we use the existing national health insurance platform. After pandemic, there will be an endemic situation where the payment to a hospital will be integrated with the current national health account. I think that's my time. 10 minutes off. Thank you, Karen. Hello.
We're just going to pass it over to Serge now. So Serge, it'll show you in just 1 second.
Hello everybody, where is my presentation? I don't know, Nicole, if you've already loaded it.
Serge, your slides are just after these ones. So once you're the presenter, if you hover over the screen and click next, your slides will show up.
So, thank you. I don't know if I am speaking. Can I start? So, if you can hear, I am therefore going to start. So, I'm going to talk to you about the analysis of free care in the context of an epidemic and the impact of the policy of free healthcare in the context of epidemics, and specifically in the context of the Ebola virus, which hit the eastern part of the Democratic Republic of Congo. And so, as you know, I'm sorry, I went too far. So, you know that generally in the context of an epidemic, the epidemics have an impact on the use of healthcare services, particularly with a destabilization of the use of healthcare services and with a reduction in their use. We saw this through the major epidemics such as SARS, and also on the Ebola virus epidemic in the west of the country, and we saw a reduction in the use of healthcare services to a level as high as 18%. So, given the context of epidemics, we realized that mortality couldn't be attributed to the disease, but could be attributed to the weak use of healthcare services, and that is how we tried to fight against the impact of these of the lack of use of healthcare services. And lots of countries introduced free healthcare to encourage the use of healthcare services, but lots of these policies had results which were somewhat mixed. Some studies showed that there were positive impacts, but some had a negative impact over the long term. And that is what we saw last year in the context of the Equator region, still in our DRC. And we noticed that there were results which were somewhat mixed in context of free healthcare, which had been put in place across the Equator region during the Ebola outbreak. And that is why we wanted to carry out another study in another context in the east of the Republic. And the methodology we put in place was to have an interrupted chronology using the mixed effect model to estimate the number of changes in the rate of the use of services during the implementation of free healthcare. We used monthly data from the National Health Information System on the use of services between January 2017 and January 2019. And for the external consultation services for common infectious diseases such as diarrhea, malaria, pneumonia, and maternal healthcare services and vaccination, what we did was collect data in health areas, in 3 different types of health areas: those concerned by Ebola and where free healthcare had been implemented, health areas which were affected by Ebola but where free healthcare had not been put in place, and areas which were not affected by Ebola. And what is important is to understand the results, which I'm going to show to you later, is that free healthcare, the policy moved at 2 speeds, with services that were free during the period of the epidemic, and then there was a change and that required a lot of money. And then we moved towards a policy of targeted free services, where there were just free consultations and maternity services, and then we had curative consultations only, and then assisted childbirth. And the results were as follows. As you can see, for example, here, during the curative consultations, the number of new cases that we saw in hospitals, in health centres, what you can see here is a dark blue curve, which shows that in the health centres with free healthcare, immediately after the epidemic, when the policy for free healthcare was put in place, it increased. There was an increase in the use of services. It tripled indeed. Which is a very significant increase in the health areas where free healthcare was put in place. We could see that in health areas affected by Ebola, but where there was no free healthcare, there was an increase in the use of services, even though there had been no change in the health services, and there was no free healthcare either. And this curve shows us that it took place at the same place. You can see the dark blue curve. There was a huge increase in the use of services during the Ebola service when free healthcare was put in place, and the use of services increased significantly in the health areas where that was available, but it increased significantly, whereas in health areas where we did not put free services in place, the use of these services hardly moved. And you can see this too in assisted childbirth and in the use of services. And as I said to you earlier, free healthcare was focused on childbirth, but after that we no longer covered that to focus only curative consultations. And then after the end of the free services, you can see, if you look at the blue curve, it's in other words the places with Ebola and free cover, you can see the end of the free coverage. You can see the use of these services significantly reduced. So the implementation of free healthcare during an epidemic, particularly Ebola in this case, increased significantly the use of healthcare services immediately after this policy was put in place, which means that the population used the healthcare services to a great extent with targeted services in areas which had free services. This increase also focused on assisted childbirth and curative consultations. We do not have good results for other services, such as consultations for diarrhea, for postnatal consultations, and had no effect at all on the policy of free healthcare on vaccinations. It's important to say that the rate of free healthcare showed a significant increase in the use of services, which therefore led to a significant increase in workload for healthcare personnel, which also led to budgetary constraints because we needed to use lots of resources to pay for the services which were being provided free of charge. So as we have seen, the implementation of a policy of free healthcare resulted in a rapid increase in the use of healthcare services, particularly in health areas which were concerned by the Ebola epidemic, and that is in contrast to what we saw in the areas, as I showed to you at the beginning of my presentation, where we had results which were not always positive and were not always good when free healthcare was put in place. But what we saw is that this was not uniform because it covered some services, whereas other services were not considered. But we think that with these policies can be effective to reduce the impact of future epidemics on the population's health, leading the population in contexts such as ours for the population to agree to come and use these healthcare services, even if generally we have an epidemic or a pandemic like the one we are experiencing at the moment, which has its impact on the healthcare services. Thank you very much for your attention. And I would like to tell you that this presentation is part of an article which is currently being submitted to an international review. Thank you very much.
Hello, everyone. Thank you so much, Serge and Hasbullah. My name is Susan Sparks. I'm in WHO Geneva in the Department of Health System Governance and Financing. I'm going to load up my slides here. So I think my presentation will hopefully try to tie together a bit of the context related to actually Ebola, which is the program of work that I'm going to be speaking on, was really kicked off post-Ebola, as well as thinking through how it directly relates to the current context with COVID. And so what I'll be speaking about is financing common goods for health. And I'll explain what those are. So first, I include this slide. This is a slide that we actually prepared in November 2019 for the UN General Assembly high-level meeting on UHC, which was kind of the culmination of the first phase of this work program that was led by our department, but in collaboration with a very wide range of collaborators from across academia and also practitioners and countries and other international organizations. It was really driven by a concern that while the UHC movement and just health in general, that there's been this remarkable progress and access to both health services, but also improvements in health, but that there was a potential neglect in some of the underlying, what we think of as population-based preventive systems that are really focused on more public health, and that there was this neglect of these substantial risks. And so the work was driven by an idea of how can we understand and really place these public health population-based functions central as part of the UHC agenda, which often does focus heavily on curative, individual services, personal services. And I like to think of it as almost a house of cards, that you invest a lot in the treatment and the curative services and hospital care and primary care. But if you don't have the foundation in place, as we're seeing right now, there's a real risk to those individual services. And also a recognition that many of these services really are not just health system-wide, but they're kind of government sector-wide and population-wide and universal in nature. And so how do we move beyond much of the thinking within the health sector, many of the investments and the financing, which often does focus disease by disease, program by program, in relation to some of these common functions. So common goods for health, so I just want to say this group that came together was comprised of a lot of economists, and it was driven by economic thinking as well, that how do we present the economic argument behind investments in these population functions in relation to the public health arguments. And so these are really population-based functions or interventions that require collective financing. So general government revenues, prepaid pooled resources, and in some small cases, we know that donor financing will have to supplement those resources. And they relate to two conditions: that they contribute to health and economic progress, and that there's a clear economic rationale for government financing intervention. I want to make that clear that this is a funding, a financing argument, not necessarily a provision argument. And because of their either public goods or not all of the goods, because I am speaking to economists, that they don't all fall within the pure definition of non-rival and non-exclusionary, but they also have large social externalities. And I want to say also that the rationale for public financing for these goods is not an exclusion to public financing for the rest of financing for UHC and health systems and health services. But that relates to a different set of market failures that relates to the insurance market and information failures and adverse selection related issues. And so this is really a different set of conceptual arguments that underpin investments in these common goods for health. And so now to give a bit of a sense of what these actually are. So what does this mean? It sounds nice in theory. So this is the functions and what the group of experts came up with 5 categories that they fall into. So policy and coordination, taxes and subsidies, regulations and legislation, information collection, analysis, and communication. So these are your surveillance systems, your research and development systems, and then also population services. And so this is an important category that sewage and treatment control, but also water and sanitation, the public health emergency operations response services. And the argument behind this is these are both critical to health security, but they also pertain very directly to issues around climate change, to issues around prevention of NCDs. And these are the platform upon which also UHC is built. And so this was the conceptual argument that we were trying to place these issues on the agenda as part of the UHC discussions. And then just to give a schematic, so then we know COVID-19 hit. And so it wasn't just our group of experts that had been ringing the warning bell and saying, okay, there needs to be a greater attention on prevention, not just related to health security, but also related to climate change, NCDs, AMR, drug-resistant TB. And what we're seeing is in real time, all of the effects on the direct mortality, the poverty economic impact, which is immense, but then also the indirect health impact. And as Dr. Thrubani mentioned, this externalities on the rest of essential health services that we're seeing really around the world, and this drop in services. I found it really interesting, Serge's talk, where actual facility use increased in the context of Ebola, but what we're seeing really a different pattern and thinking through some of the variables that might affect the differential access issues. So this is a schematic that gives a sense of how to put these pieces together a bit. And so I want to put this here because I also think that there's a real, just as the agenda was really set to try to bring together the health community around these common sets of functions. But also now the risk is that in the context of COVID, how do we make sure that financing for health security isn't viewed as something distinct and separate from financing for UHC? And because we know that these are very much, in many sense, overlapping, but also complementary functions. So there are distinct aspects, but how do we make sure that as we hopefully move towards a Build Back Better and stronger health systems and more resilient societies, how do we make sure that there's complementarity between these two aspects? And so one starting point is really the investments in these common goods for health. So now, because this is the financing special interest group, just to give a sense of, we did as part of the review, and so there's a special journal issue of Health Systems and Reform on this topic that has many papers, and the paper that I was most directly involved in was reviewing, the financing of these goods, water and sanitation services, health security related issues. And so 3 things that we know. One is that public financing is central. I mean, this is common for common goods for health, but also for UHC. So the revenue question is taken off the table. We know where the revenues need to come from. And then also because of the costing work that's presented in a lot of these papers, we also know that these investments are relatively affordable. They're not high cost interventions. And so that's one set of issues. Then the other issue is the system level unit of analysis. How do we have these discussions across the entire sector? And then focusing on efficiency, because even if they are low cost, how can these investments be made in a way that there isn't duplication and overlap, and that we're really leveraging across not just the health sector, but also across the entire government public sector. And so what we found in this review of both budgets, but also the literature, and in speaking with policymakers, is this issue of fragmentation. It's not to say that fragmentation is always bad. Specialization targeting is really important. But in the case of the commons, so in the case of these common goods, it can present really important challenges both within the health sector, across sectors, and then across levels of government. So the decentralization issue. And so it'd be interesting to hear more about how that's being navigated in the context of Indonesia right now, which is a highly decentralized setting. So without going into too much detail, one issue is the fragmentation within the health sector. And so as we look at surveillance systems, as we look at labs, as we look at information systems, as we look at transport systems, how can these be brought to cross-cutting way? Because what we saw as part of the budget review, but also the financing review, is that these are often fragmented by disease. And so how can there be more consensus about bringing together some of these common platforms and some of these common issues? And also this coordination between public health and in many contexts, health insurance. And it's often viewed as health insurance is the purveyor of UHC. But as we're seeing, these public health functions really are also core to the UHC movement. And so how can the planning and budgeting and coordination functions help to ensure that complementarity? And then the other issue is this multi-sectoral nature. And so what we know is that many of the impacts are on health, but many of the interventions in relation to common goods, but also in relation to health security, as we're seeing, lie outside of the health sector. And so how can ministries of health engage more effectively in the water and sanitation discussions and budgeting process? How can the sewage treatment and the sanitation services, how can those interactions and the environmental issues around regulation, and this also goes with the health taxes issue. And so really seeing the multi-sectoral nature and the need for that coordination. And one way is thinking about different budgeting options. And so the rigid line item budgets can often work against this flexibility. So how can you put into place or use the budgeting methodologies that are program-based budgeting, performance orientation, to allow for joint orientation around KPIs and other performance indicators. And then this issue across levels of government. And there's actually been a lot written in the context of COVID in relation to this issue of coordination across subnational entities, but also what happens when the revenue generation, the revenue mobilization function sits at the subnational level. How can the national level really mobilize a national response and in many respects a global response? What are the regulatory mechanisms, but also matching grants? And what are the financial flows that need to be put into place to allow for that response? So lastly, just thinking about what comes next, to finance common goods for health and to think about what comes next, okay? So once we come out of this emergency firefighting role, what can be done? And so what we saw is this pooling of financing and consolidating governance structures in a very targeted way. And so again, thinking about that certain surveillance functions, how can that surveillance function really be built and brought together across the sector? And that has implications for laboratories, for information systems, for the workers that have to input that information and the analysis function. And then aligning budgeting with more efficient common goods for health delivery. In the case that coordination is needed, how can either there be flexibility in the budgeting process or in the reallocation process throughout the year, but also in terms of performance orientation and joint KPIs. And then in the decentralized setting, recognizing the special nature of these common goods for health and prioritizing systems and financing across levels of government. And so really understanding in this context, what are the potential financing levers, because there's also important policy and regulatory levers as well. And so I think there'll be a lot of learning that comes out of the current experience that can lend itself to both good and bad experiences in terms of this financing agenda as part of the overall UHC movement. So I will turn it back over to Karen now. Thank you.
So thanks to all of our speakers for those excellent presentations. So 2 questions have come in from the floor, and so I'll ask those. But if in the interim you have some more questions, please put them into the chat box, and we'll make sure they get queued up if there's another round of questions. So the first question is, I think, probably to all speakers, which is obviously COVID is going to be changing so many things in our in health systems, especially with regards to the burden of disease. I think the burden of mental health issues that are going to be changed. COVID's not going to go away. What do the speakers think in terms of how this might change the priorities for the allocation of total health expenditures or general government expenditures in countries? And then a question about, we as many of us who are researchers, what do we think the research priorities should be for those of us who are interested in these research questions and how they could support things that you might be dealing with in your countries or in your context? So I'll pass it over to the speakers.
Hello? Okay, I think I'm broadcasting. So on the first question, I think that, what we all hope is that what we see now is that there's a clear window. There's a lot of money that's been mobilized. A lot relates to the economic response related to COVID, but there's also clearly a lot of money going into the health sector and thinking through about the vaccine. And what I hope is that these funds are channeled in a way that actually builds systems, strengthens systems. Some of our concern post-Ebola was in working with colleagues from Liberia was that there had been a big rush and a lot of discussion about changing financial flows, pooling funding, building systems, but little action in terms of actually realignment. And so I think that that's a big hope from my side, and also that some of the health community, that we come together in a much more coherent way in terms of our relationship with ministries of finance and how we engage on these topics.
Yes, thank you for this question. I think that in the context of epidemics, like what Susan said, it is important to guarantee sufficient financing for shared health assets, because that will help us to guarantee the implementation of healthcare functions which are needed to prepare and to respond to the crisis. Unfortunately, many countries' investments in preparation for epidemics have not been sufficiently prioritized in recent years, and it is important for us to be able to finance shared assets in order to prepare all of the mechanisms which must help us to respond to COVID-19, and all the mechanisms which will enable us to face up to this challenge in a better way. And as I said in my presentation, there needs to be sufficient financing to reduce the problems with access to health care in order to enable establishments to diagnose and treat everybody who needs it, and to bring people to health services, because they know that by going to health services they can be diagnosed and treated whilst they are ill, that what we saw in Africa is that lots of people go home because they did not know how they were going to be cared for within health structures. So what I can tell you, that is what I can tell you in terms of this question.
Hello. Yeah, I would like to respond to a question by Muhammad Haq from Tasmania that after the COVID, the Indonesian government really have a higher awareness of the correlation between health and economic, and therefore attention for the health reforms very high. Just recently, 2 weeks ago, the president, in his address to the parliament or Congress, requesting the fundamental reform of our health system after many government officials experience how difficult these healthcare issues and how big the impact of healthcare issue to the uh, economic development. I think the COVID provide a very good lesson to reform our health system. Indonesia, our health system has been underfunded for more than 3 decades. So this is a good opportunity for us to evaluate our health system. I think in many countries, the same thing true, especially in low middle income countries. The burden of disease certainly changed, but most of the chronic disease have long-term correlation between the current behavior, for example, for the prevention program to the impact of the healthcare costs, to the impact of the disease occurrence. Therefore, attention relatively not as high as for the communicable disease like COVID, that the impacts very quickly seen to other sectors. Thank you.
No, thank you. I just wanted to quickly answer Virginia or give my own personal answer to Virginia's question on the research priorities. And I think what we're seeing in the current context as economists is the interface between politics, economics, financing, and I think that we really need to understand, I think we can learn from past experiences in relation to this UHC question, because we know that crises can jumpstart action in terms of UHC progress. And we see that in Thailand, we've seen that in Turkey. But I think understanding some of those political dynamics and really bringing those into our analyses, I think will be really important in terms of how we think about engaging in this agenda in the next months and years as well. Thank you.
Hi, so I actually had a question for Dr. Thabrani, and I'm actually wondering too, given people on the phone and on the line, if they may have some answers to these questions as well. If so, you can put them into the chat box, your own answers. I noticed you said that there was a very large decline in use of health services, including at some of the private sector facilities. And I know the government has responsibilities to some kinds of facilities, but has different types of relationships with the private sector. And so I'm wondering, what's happening in terms of dialogue, in terms of how they're thinking about propping up or sustaining or help providing support to the private sector to kind of help them get through this very challenging time from a health financing perspective.
As for other business entities, the government providing incentive and kind of social assistance program to overcome economic impact of all business entities, including the private hospital. So the government has been relieving, for example, income tax that the hospital and other businesses alike are given, relaxing of the tax payments, and the government subsidizing those who have low income under in Indonesian rupiah 5 million who receive um, additional money from the government just to make sure that the business can run smoothly. In addition to that, for the health sector and the national health insurance, currently the government is increasing the funding through increasing contribution and subsidy for low-income people, especially for the informal sector who are unable to contribute during this COVID. So the national health insurance could have more liquidity and pay the hospital in time. Currently, there are good progress on that, but still people afraid to come to a hospital because they're afraid to get contacted by this virus. And therefore, the claim that the hospital could submit to national insurance decreasing until maybe hopefully by January we have a vaccine that will be introduced currently under the phase 3 vaccine development in Indonesia in collaboration with China and our homegrown vaccine testing. So that's probably some information. Thank you, Karen.
Yes. So the question which Susan asked me, I think it is about trends in terms of data on financial protection during the free healthcare period. I think this is a very important question, which is very relevant. And yes, during this study, we had to focus on data on the use of services and see the impact of the policy of free healthcare on the use of healthcare services. But it would have been interesting, in addition to that, to track the progress, use the indicators to following universal healthcare coverage, using these indicators relating to financial protection. We could, in addition to the study which has already been done, we could have seen the proportion of women covered by healthcare insurance or the number of direct payments in relation to the total healthcare expenditure. For example, see the number of payments in terms of total household payments, and we could see the catastrophic expenditure levels of expenditure on household healthcare. And we could have seen other indicators, for example, the incidence of poverty, for example. I think that could be another study which would cover the collection of data in the context of national healthcare finance, and we could try to collect these different levels of information. But in terms of this study, it was not collected, even if, as Susan says, I think it would be relevant, but I think another study could enable us to focus on trends, on data in terms of financial protection and the impact of free healthcare on household finances, with specific indicators on financial protection for households in the context of healthcare cover. Thank you, Susan, for this question.
Hi. So there is just one last question, which is for Dr. Thebrani as well, which is, what do you think the impact of increasing national health insurance premiums at this time in Indonesia would be on outcomes? And I think this will be the last question. So if I don't speak to other people again, thanks for coming, and we'll leave the last question then to Dr. Thebrani.
Virginia and Karen. Currently, this year, the government has affirmed that the premiums increase in terms of the premium for the informal sector, while for the formal sector remain the same 5% because of the increasing salary. So automatically, the revenue of the JKN increase. So we already have some simulation, the financial modeling, looking at this year, the national health insurance will not suffer from deficit because of the increasing contribution, and the government subsidize contribution for the informal sector. So the informal sector will still pay the previous amount of money. The gap with the new raising premium is financed by the national budget as a subsidy for this year and next year. And then the new contribution fully paid by the people will apply in 2022. Yeah. That's to ensure that people get access adequately. The national health insurance will still have enough money, maintain liquidity and solvency, but access will be maintained. Thank you.
Thank you so much to all of our speakers today and to Karen and Virginia. Like she mentioned, that was the last question, so we are done for today. Thank you again for everybody who listened, and the recording of the webinar, if you did want to listen again, will be available in the next few days on our website. We will be sending it out afterwards with, once it's available, with a post webinar survey if you're able to fill that out as well. So thank you everyone and have a wonderful day.